So today we are going to discuss hepatitis C medication access and reimbursement. The presentation will be by Dr. Clark Allen, our pharmacist with Region 1. And as I mentioned, some of you all had already joined a little early, but if you've not already registered to receive your continuing education credit through the Southeast AIDS and Education Training Center, please do so. You will have to attend the full session, but then you will also complete a post-session evaluation survey, and then your certificate will be emailed. You can join by the QR link, or you can also visit the QR code, or you can also visit by the link. And also, if you've just joined, if you do have any technical issues, please feel free to message Kimber Miller. Her information is in the chat, as well as the link to the continuing education information. And just a few introductions and announcements before we lead into the presentation. Please go ahead and drop your information in the chat as far as your first name, your role, your organization, and if this is your first echo session. Right. I see some familiar names and faces. All right, well, we'll go ahead and get started. There will be an opportunity to ask questions at the end of the presentation. And please feel free to come off mute when that opportunity arises. But otherwise, I will go ahead and pass it off to Dr. Clark Allen.
Thanks, Lizzie. So yeah, today's session is going to be over medication access and reimbursement. Really looking forward to this one to explain kind of the pharmacy side of it and kind of things that maybe you may not see in the primary care setting to hopefully fill in the gaps of knowledge to like understand what happens after you send that prescription. Next slide. No conflicts of interest to disclose with the presentation today. Next slide. We've got a couple of objectives today. The main ones we want to look at is clinical information revolved and required for treatment evaluation with the provider themselves and also the insurance company, looking at payer sources and formulary options, recognizing what barriers to overcome. That could be clinical barriers, social barriers, or cost barriers. And we'll talk about some of those things today, as well as we want to explain medication access process for patients without insurance as well. So we'll go through both patient with insurance and without insurance, and because they differ in some instances. Next slide. Abbreviations for today, most of them are very typical for medical labs, CBC, CMP, INR, and the one that's different for some people may consider a patient assistance program or PAP. I consider it PMAP to specify this is directly related to a medication. We can have PAP assistance with hospital visits and things, so I like to distinguish it from PAP and PMAP for this is just a medication specific assistance and not assistance in general. So I like to specify that. So that's why you'll see me or hear me refer to it as PMAP. And then SVR12, sustained viral response 12 weeks after treatment. Next slide. So we want to first define terms. What does medication access mean? So I wanted to do a Google search and make sure I've got a definition that we can work with. So we want to say it is, or we're going to say it is the ability of the patient to receive the most appropriate medication for their medical condition and improve their overall quality of life. So this process can involve patient-specific challenges as well as health system limitations and barriers. So we want to make sure we talk about how to navigate or help the patient navigate through this medication access pathway the best that we can to help them overcome barriers when we can, or also direct them on how to overcome barriers if we can't intervene on their behalf. So next slide. Oh, back one. Come back one slide. So these are the 4 evaluation factors when we consider for a patient without or with insurance, I should say. These are things that I take into account for each patient. I do it in a stair step. I first start out with the bottom rung of the clinical information. We'll do when we exam during the patient interview, and we'll also get lab work associated with that. We'll also look at drug interactions with each patient case. That's kind of the next step up. And then we want to look at what is the patient's insurance status, what is their payer source, and then we also want to look at the patient's the payer source's formulary. That may dictate which medication we pick for hepatitis C treatment. And if all of those things align and there's no restrictions on any of those things, then we will of course offer it up to the patient to let them decide if they prefer a 1 pill once a day or maybe the 3 pills once a day for a shorter course. So we'll leave it up to them if we have that option. But more times than not, there's going to be a restriction on one of those rungs before we get to patient choice that kind of dictates which medication we can use. But there are times when it's great to kind of have both options available, and we can let the patient decide which one they prefer, whether they prefer the 12-week course or an 8-week course, with or without food. We like to have those options available if we can. Next slide. Now, as far as clinical information, this is not going to be the only stuff that providers are going to evaluate when they first start out, but I want to make sure we mention things that do need to be evaluated from a laboratory perspective for the provider as well as for the insurance. So this is going to be specifically for clinical information as far as lab work. There's going to be other things that providers do as far as evaluations for indicating a patient for hepatitis C treatment. So we want to first start out with the CBC, CMP, INR. Those are things that we can use to evaluate liver function for those patients. We also want to make sure we're getting a hepatitis B panel before we start treatment. We want to make sure we know who is potentially active of hepatitis B, and we need to address that issue first before starting hepatitis C treatment, because we know there is a risk of reactivation of hepatitis B. So definitely want to get that on the front end. And then the next 3, or the bottom 3, are going to be hepatitis C specific. We want to get a viral load to make sure they actively have virus that's indicated for treatment. We want to get a genotype. Now, this is going to be one that's plus or minus. We'll actually, whether have insurance or not, but most insurance companies, plus or minus some, we're still kind of, there's ever changing of whether they are required or not. For the most part, we still order genotypes on everyone just in case the insurance company is going to be firm on requesting that information before they will approve treatment. So we want to abide by their rules and make sure we're providing their information that they require for approval of their authorization. We also want to get some type of fibrosis staging. We want to look at the liver, want to be able to stage it using one of the 2 methods that are honored by most insurance companies. That includes a HCV FibroSure, which is a blood test, or you can also, if you have access to a fiber scan, you can do that as well. That's an elastography ultrasound that kind of looks at the liver visually and can kind of stage the liver from that perspective. So one is a little more cheaper, the FibroSure. If you've got access to the machine, you can get instant results, which is great because you can start medication quicker if you don't have to wait on the lab results. If you've got everything already available as far as the viral load and genotype, and all you're waiting for is a fibrosis staging to stage the liver, and if you have access to that, you can start treatment much faster if you don't have to wait on those lab results. So it all depends on, these are the main things we get for any new patient that comes to our clinic with 0 lab work. We get patients from the health department that won't have any lab work, and these are the main labs that we will get. One, to evaluate from our perspective, to make sure we're looking at everything, to evaluate the patient from a laboratory perspective, and then also to make sure we meet the needs of the prioritization specifications as well. Viral load specifically, I want to make sure I make a note of that. If you get referral documents, or if you've got a viral load from 3 or 6 months later or in the past, I want to make sure there's an up-to-date one. There are insurance companies that you can run into that will require the viral load be 6 months or maybe even 3 months in recently, and not more than that. There's a potential chance that they could restrict or make you want to get a new viral load. So I want you to be aware of that. If you have a viral load from maybe a year ago and you're ready to start treatment now, you might want to recommend getting a new one if they do have an insurance plan, in case there's a potential you could run into that with them requesting that information be more up to date or more recent. Next slide. So these are the main payer sources that I run into in my clinic. Most of them are going to be Medicaid patients. I see a lot of TennCare patients and a lot of Medicare patients. I also see commercial plans. There can be commercial plans through the marketplace, through the Affordable Care Act. We can also see employer mandated plans that they use through their employer have a good mix of those things, and we also see patients without insurance as well. Don't really see too many government plans that work for either the military or work for federal employees. I don't really see that much, but those plans exist as well, and they have their own formularies. But I want to make sure we mention all the different payer sources types out there. And pretty much all of these plans are going to request most of the information that was just described on the previous slide. Next slide. So now let's talk about specifically the access to care with Medicaid. So I wanted to kind of paint a picture. We've got on the left side February of 2023, and then the most recent one that I saw on the website for the state of Medicaid access for the website is August of 2024. We can kind of see that there's several states that have gotten lessened their restrictions on hepatitis C treatment. Tennessee has been about the same. They have changed their primary or prior authorization criteria a little bit to make it a little easier, but there is some restrictions still there and present. We do still require prior authorization. They do still ask several questions, but it's good to see that there's no red remaining on the map for hepatitis C treatment in the U.S. There is some states that are still slowly but surely changing their ways, which is great. That allows more patients to get treated faster and not be waiting on things like having advanced fibrosis before they're allowed to get treated. Those things have been removed in pretty much all states now, which is great. I believe in 2020 or 2021 is when Tennessee removed those restrictions, which made it much easier to get patients started on treatment that didn't have any restriction like that. So just want to paint the picture that we've got great movement in the access from Medicaid standpoint, that it's getting easier and easier to get patients on medicine with that payer source. Next slide. Now, I want to make sure, because this echo session or echo entity is associated with pregnancy and postpartum mothers, so I want to make sure I give a slide to them and talk about them specifically. So women who are currently pregnant, we want to make sure that they're aware that they can enroll in TennCare, so state Medicaid program, so they would be eligible to get on TennCare at that point. Now, there's a main stipulation for eligibility of TennCare. Now, it's if they're pregnant, they also have to be. It's also based on income. It's also based on citizenship for them to be enrolled. If that were not the case, if they were not a U.S. citizen, then there would be probably an instance where we would utilize financial assistance or patient assistance in that case. For right now, the guidance is still to defer Hep C treatment until once they've delivered the baby, and then we can start that process. Once they are postpartum, then we've got 12 months that the patient will continue to be enrolled in TennCare. So that's 12 months that we've got time to get them started on medication for hepatitis C treatment and get them treated before that were to end or if we're to continue. And then, of course, we want to make sure we counsel that mother to make sure they have follow-up with their newborn, to make sure they're screening their newborn for hepatitis C at the appropriate time points, to make sure we have them for follow-up as well if they are indicated and need treatment down the road, because we have to wait, but there is certain time points that we've talked in previous lectures and sessions about when is the appropriate screening times. All the medications, if a patient does have TennCare, they are eligible for all three medications on the market. So all three of the main first-line agents for treatment are on the table. So that gives us great flexibility, whether there's other instances where there might be restrictions and other things that we need to use a certain medication. It's great that we have the full array of all three medications to have that flexibility. Next slide. So I've talked about a lot of fun stuff. Now let's talk about a couple barriers regarding medication access. And this is probably where a lot of questions are going to spark the further I get into this. And I want to make sure I have plenty of time for questions along the way, because this is my realm of what I do on a daily basis, what I have to troubleshoot and triage. So I want to make sure that I have time for primary care doctors to chime in with things that they face as well. So I tried to make a pretty graphic here of all the barriers that I face. So I want to make sure I describe them. So cost can be whether with insurance or without insurance. Patients can think that they can't afford it or the copay is too high. So there's potential issue for barrier there. Adherence is more of a patient specific thing, whether they're not taking the medication or not picking it up from the pharmacy on time. That's a potential barrier of them not being able to, one, get the medication or continue the medication because they didn't pick it up on time. So that one's kind of a not necessarily on the front end, maybe during a treatment adherence barrier, or maybe the PA expired, things like that could have happened. And as far as providers, there could be a barrier there of their needing a consultation with a specialist. And that's where this echo session comes into play as well. If you've got an insurance company that's requiring you to be referred to or in consultation with a specialist, we have that facility here or ability here for you to present your patient case here, and we can be that specialist consultation in that process. So we want to make sure we make a plug for that. If you've got hepatitis C patients that you're running into that barrier, that we can facilitate with that. Social factors can also be barriers, whether it be homelessness or poverty or without a cell phone, unable to contact them, mental health things, potential addiction. Lots of things can also be social factor barriers that can maybe get in the way of being adherence and compliant to the medication. And then formulary and insurance, I kind of split those out because they're different things that can run into be barriers. Insurance restrictions can be pre-authorization restrictions such as sobriety or substance abuse history. It could be fibrosis. Don't really see that anymore, but every now and then we'll see a substance abuse or sobriety issue come into play. I know Lindsay recently had one, and then right after that, I actually had one as well, that it required that the patient be 6 months sober from alcohol and substance abuse for 6 months, or excuse me, 90 days, not 6 months. So that patient, he was drinking alcohol, wasn't abstinent. So now we had a conversation with the patient of working to get becoming sober from alcohol, and then starting that 90 days of being sober. So that way we can meet the criteria of his insurance company, and then we'll write a letter saying that we believe he's been sober, because I'm going to follow up and check with him along the way to make sure we're still doing what we can to make sure we're honoring what the insurance requires, and also making sure that he doesn't fall out of care, making sure I haven't forgotten about him, because it's going to take until the end of April until I can follow up and potentially get him started on medicine. So it was a bit of a shock. I haven't seen that stipulation or requirement of total sobriety or abstinence from alcohol in quite some time. So I was a little caught off guard by that. So just want to put that plug out there. There's potential for those things. So I wanted you to be aware of that from primary care doctor perspective. And then as well as formularies, there can be barriers to the specific medication you want to try. Maybe you want to try Glucaphor for prevention for a trade name Mavorite, but the insurance is preferring Sofosbuvir, Paltusvir, trade name Eclusa. And sometimes that there's going to be a case of maybe you need to do an appeal to get that medication approved because you have clinical evidence and reason as to why you want your medication. So sometimes there's going to be a little extra documentation required to get over that barrier. Next slide. And this is kind of what I do every day. So I want to kind of walk through the evidence walk through the procedure that I do every day. So prioritizations, they can be done online portals. Most people will probably use Cover My Meds. There are certain insurance plans that maybe have their own portal that you'll have to log in and submit a PA through that specific portal. There can also be paper forms. I'll say in my perspective, most Medicaid plans still prefer paper forms. So that includes Tennessee. I still print out the form and fill it out, and then I'll fax it in. Arkansas and Mississippi are the same way. So I still print out paper forms and we'll fax them in. Pretty much everything else is online. It's very rare that I'll see a commercial plan require me to print out some paperwork and then fax it in. So just want to say there's different ways to do PAs, and sometimes it's dependent on the insurance company will tell you what to do. And then once you've got the approval, then is a new challenge, if you haven't entered these waters before, is that most hepatitis C medications do require it to be filled at a specialty pharmacy. And depending on the insurance, most insurances will not worry about you filling at a specific pharmacy, but some of them do. So Medicaid and Medicare plans don't really have a certain stipulation. They can give you recommendations on specialty pharmacies that can fill it, but then there's also some commercial plans that maybe be employer-specific ones that they will be contracted with a specific specialty pharmacy, and that's the only pharmacy that will fill it. So those are the things that sometimes it'll take you a minute to triage and figure out where those things need to go. And eventually over time, you'll kind of learn which insurance plans have specific mandated or dictated specialty pharmacies you have to use versus ones that are okay that you can fill at your at a local specialty pharmacy or one that you work well with. You can use CVS Specialty, Walgreens Specialty, and there's other large entities of specialty pharmacies around the country. And there's also more local ones that if you can build a relationship and you can have a more direct line of communication with them and get things done quicker and streamline them. We have that advantage here at Regional One Health, where I see patients in the clinic, and I also, if I'm able to, I'll fill their medication. That way I can triage their copays, which we're going to talk about just now. and also do the counseling. So I kind of do a one-stop shop. I know that's not ideal for everyone because you don't have a pharmacy attached to your primary care service, but it's something to consider. If you have a local specialty pharmacy, to maybe build a relationship, that way you can kind of keep a closer eye on patients' refills and things like that, and they can kind of reach out to you quicker if you've got those direct lines. So that's just my 2 cents on that. And then, of course, copay assistance. Now, this is going to be something that a lot of patients and providers, it becomes frustrating because you want to know how much it costs and how much the copay manufacturers can work with. Now, copay cards are only good for commercial plans. It won't be good for Medicare plans or Medicaid plans. So that's out for those. But for commercial plans, you can use copay cards for brand or generic. So if you've ever seen, if you've ever had to prescribe the authorized generic, notice how it says authorized generic. There's a certain that language allows them to use a copay card. So Asegua is kind of in combination with Gilead, and so they're able to use copay cards for the generic medications. And we'll talk about we'll go into a little further detail on the next slide. But but for patients with Medicaid, they don't really have much issue with copays. It's usually going to be $1.50 or $3, so don't really have to do anything as much as copay assistance for Medicaid. But then Medicare, now those patients can have a large deductible. Sometimes you can run into issues, and that's when I reach out to third-party foundations. The ones that I use most likely are going to be HealthWell, the PAN Foundation, PAF, which is Patient Advocate Foundation, and then maybe the Medicine Foundation. Right now, I think I've run into an issue where they're all closed for hepatitis C funding. So that happens sometimes, and you may have to wait until there's open funding for the hepatitis C disease state before you can get funding if you've run into that before. So there's a potential barrier there is if the foundations don't have funds for hepatitis C patients. So there's a potential issue there that is cropping up more and more in recent years. And then, of course, write your questions in the chat, and I'll get to them at the end if you've got questions about anything that I just said. But we'll keep it moving for right now to make sure I get through the slides and have plenty of time for questions. So I mentioned about copays. So I want to make sure we talk about copays specifically because this is kind of the hardest thing to understand. So yeah, Gilead has brand Epclusa and brand Harvoni copay cards. They also have authorized generic copay cards as well. The difference between the two that I've found, and it's actually if the insurance plan prefers brand, I would go with brand for this reason. When I put it on the side bullet point, can request additional funds if necessary. When you usually, based on my experience, you get $6,000 off the front end, and then if you need more, if the copay is larger than that, you need to call. You can call Gilead and ask for additional funds. That is not the same case with the authorized generics. They only give you a hard stop at only $6,000 of assistance. So that could be limiting if a patient has a larger than $6,000 copay, then you can run into issues there. So there's a difference between those two cards, and there's a value. If the insurance company prefers brand, I would go with brand just because I know there's more flexibility with the copay cards. AbbVie has a copay card for Maverick. I haven't had much issues as far as getting additional funds for that one as well. But I wanted to make sure I made the specification between the Gilead or the generic versus the brand of Gilead and Asegua. Next slide. So that kind of includes everything as far as getting medication to the patient. So lab work, PA, copay assistance, those are kind of the main steps to kind of work through. And there can be troubleshooting things to kind of work through at that time. So now we can shift gears a little bit to patients who don't have active insurance. Next slide. So the stair step remains the same, except for one step is a little different. Clinical information, of course, drug interactions, but the third step is not going to be insurance or payer source or formulary. It's going to be income documentation and living situation, because we want to make sure that the patient is going to be financially eligible to get the medication covered for free from the drug company. So that'll be where if a patient doesn't have insurance, you want to make sure they bring in income documents. And we'll go to the next slide. Oh, it's actually not going to be on the next slide, but we'll talk about agents first. So the medications for hepatitis C treatment, they all have assistance programs, the brand names, that is. I haven't looked to see if there's a generic, or I guess you could still use the generic. I just have yet to do that. So Gilead has program for Epclusa, Harvoni, and Bosevi, and then AbbVie has a program for Mavyret. There's a formal line to print out if you need the patient assistance application. It can also be done online if you want to through the iAssist portal for Gilead products. I haven't tried it for Mavyret. I usually just print out the form and fill it out and fax it in. That's usually my method of how I work with those two programs. Now we can go to the next slide. So this is kind of my process for how I work through a patient without insurance. So I work first to print off the application. If I want to do it, fill it out and fax it in, or you can do it online. Then the income documents. So the income documents can be lots of different things. I think it's going to be covered in the next slide, but I'll go ahead and talk about it. It can be tax documents, pay stubs, if they get Social Security, if they get disability, if they get food stamps. I'll ask all of those things to see what type of income they have per month. And so I try to mention all those potential options for income, source of income. That way they can bring whatever they have, and that way you can show the drug company that this is how much, this is what they get per month from these sources. Do they meet criteria? And you kind of go from there. Now, if a patient doesn't have insurance, that's when you want to think about doing a letter and kind of explain their situation as far as why they don't have income documents. And then you can also do an eligibility check. I have a way to check if they are eligible for TennCare through something called Passport One Source or Experian. That's something that I can talk more about offline if I need to, as to how we utilize that at Regional One Health. But it's a way to see if they're eligible for the state Medicaid program. That's what I can do. And then I can also ask if they've ever tried to sign up for an Affordable Care Act plan, or based on their income, I can probably tell if they are able to or not able to afford one of those plans. So those are kind of the steps that I walk through. Next slide. Then kind of here's the layout of the income documents that I mentioned. Social Security, food stamps, disability can also be other forms of income if they have those things. And of course, like I said, if there's no income documents, I recommend writing a letter or something that explains why they don't have income, and who do they live with, because they most likely live with somebody, or are they homeless. Want to know that situation of living status, because that can be a potential barrier, and we want to make sure we can overcome that barrier. Still want to treat them even if that is the scenario, but we need to make sure we have that information on file. If a person gets paid in cash only, that happens sometimes, we will just write that in the letter as far as putting what they get paid in cash. Do they work for just a lawn service and somebody pays them on the side or something like that? They do odds and ends jobs. Those are things that I would write in a letter to kind of explain this is their income, but they don't have any official documentation of how they can show proof of that. And that usually is honored and accepted by the drug companies, because I'm writing it when they're in the clinic and I'm having the patient sign it because they agree on it. So we kind of write that letter together. And I think on the next slide is going to be kind of more things to address. Yeah, next slide. So I want to make sure I establish for patients when I'm filling out application for medication assistance, we want to say, have they applied for insurance in the past? Are they eligible for TennCare? Have they applied for Affordable Care Act? Are they not able to afford it? Kind of, you can put those things in there. We can also include their income documents, and then also the living situation. Do they live with a family member? Do they live with a friend? Kind of what's that setup? And those are the things I like to address to kind of explain to the drug company that this is their status, that they just don't have the money or the means to get the hepatitis C treatment based on the price. And these are the reasons why we're reaching out to you to see if they're eligible to get it for free from the drug company. Next slide. And so these are kind of things to reminder for both scenarios. So once a patient gets started on medicine, I want to make sure that they, when they start, because you want to know when they start, to when they finish, to when they need to come back for cure. If you want to, you can have them follow up in clinic during treatment or at the end of treatment, whichever you prefer. Or if you want to just follow them at the end of cure determination, you can do that as well. But keeping a point of contact is always something that I prefer, just making sure I'm still letting them know that I'm monitoring their care, and I want to make sure they're still taking the medicine and doing well on it while they're on it, to make sure they complete the full course. And then we also want to provide counseling. The pharmacy is likely going to do the counseling, but from my perspective, even if it goes to a different pharmacy, I still like to do my own counseling, because one, I want to counsel them and also know when they started. So that's kind of what I do. Once I get them on the phone, I want to go through my counseling points as well to make sure I fill any gaps that the pharmacy may or may not have covered, just because I like to be in line with my patients and really take care of them. Be mindful of prior authorization windows. This is a biggie, especially when you're sending it to specialty pharmacies. Want to there's only a finite amount of time that most insurance companies will approve the medication. Usually it's going to be the exact amount of time it takes to take the medicine. So that's usually going to be about 12 weeks or 8 weeks, depending on which medication you pick. So it's be mindful of that to know when the patient starts. That way you can kind of gauge based on looking at when the PA is going to expire, will they be able to get all the refills in that window of time? Because there have been times where I need to renew the PA to make sure that they can get their final fill. If there was like a delay in getting started on the medicine, using other pharmacies, sometimes that can happen because they need to do other things to get the patient enrolled and all those type of things. So there is a potential for that to lapse, and you want to make sure you're on top of that they're able to get all 3 fills if that window expires, to extend that window to make sure they got everything. Be mindful of potential changes in insurance. Now, this doesn't happen very often during the year, but if you start a patient at the end of the year in November, December, and you know they're going to fill a final fill or second to final fill into the next year, make sure that you know if they're going to change insurance plans, if it's a Medicare to Medicare or commercial plans changing. Make sure you're aware of that, because you will need to do a new PA, and it potentially could go to a different specialty pharmacy too. So those are 2 big things that I worry about and are always mindful of around the change of the new year, because I know there's a potential for that, and I try to stay on top of that to make sure there's no gap in treatment during that transition period. And of course, what goes without saying, stay in touch with the patient during treatment because of these various things that can happen along the way, making sure they're taking their medicine, making sure they're not having any issues with that. And of course, have their appointment on the schedule for SVR 12, knowing and telling them the importance of following up for cure determination, because of course we want to know that they got cured as much as they do. So always reminding them of that final appointment is of value. I think with that, I think that's everything. Oh, I got one more slide. I thought I'm getting ahead of myself. The most important thing that people care about, medication reimbursement. They want to know what type of reimbursement do we get as far as specialty pharmacies. We'll go to the next slide. Now, reimbursement rates are all over the place. I'm not going to lie. With each payer source, Medicare, Medicaid, and commercial, everybody's different because we've got deductibles, we've got max out of pockets, we've got copay cards, we've got all kinds of stuff to triage and kind of work through. Now, PMAP, we can go ahead and put that as saying we're not going to get reimbursed anything because that's just come from the drug company for free. But as far as Medicaid, we'll start with Medicaid first. Medicaid, usually we just get reimbursed a dispensing fee, usually about $15 or so. That's not much of anything, but that's what we get paid for them. Now, Medicaid or Medicare and commercial can vary greatly depending on deductibles and things, and using those copay cards and third-party foundations to help out get those copays under control. That way the patient cannot pay anything for the drug. Can be sometimes, if everything goes through accordingly, several $1,000s, but it all depends on working through those other things. And so I want to mention right here, with copay, with commercial plans specifically, Medicare, there potentially is going to be deductibles that you have to meet, and sometimes there's going to be a lot of potential out of pocket. That's when I use third-party foundations. But commercial plans, there can be things called copay accumulators or copay maximizers. That may be a new term to people on the call, so I want to make them aware. There are certain insurance plans that can have these plans in place. And I want to make sure I've got definitions right. I can understand it in my head, but I want to make sure I explain it to you guys. Copay accumulator program, it prevents manufacturer copay card assistance from counting towards a patient's deductible or out-of-pocket maximum, essentially making the patient responsible for full cost once the medication assistant runs out. So it's designed to, one, get the reimbursement from the copay card, but then the patient is still left with their deductible and max out of pocket. I don't like these things, but we need to know that these things exist and how to navigate around them. Usually the copay card companies are aware of these as well, and they're going to work and do a benefits investigation to make sure that this is not in place, that we're not going to set the patient up to fail on the next fill. So they're going to be working with you as well. Copay maximizer, a little different, but essentially the same thing. It sets the patient's copay to the maximum amount that the copay card is going to allow. So we'll just say $6,000. And then once that is maxed out, then they'll still keep the patient won't have to pay anything. But then the next time, once that has been exhausted, then they will have still their out-of-pocket limit will still have to be met after that. So it's not advantageous to the patient. And those are things that we can run into as providers and the pharmacy, and things that we want to make sure that we're aware of, that we don't want to start a patient on medication if something like that is in play. So those are essentially new terms for you guys. Feel free to look them up on your own to kind of understand that there are some commercial plans out there. There is some legislation that potentially Tennessee banned these things. I haven't run into them that much, but I do know they're out there in the wild. So I just wanted to. I think those are the main things I wanted to emphasize today. And in the interest of time, I'll open it up for questions.
I have one. We've been having an issue with both Gilead and AbbVie. They're counting people who have CoverRx as having insurance, and it's been progressively getting worse.
Yes, so I can. I've dealt with the same thing. I know what you're talking about. It's very hard to get them to understand what CoverRx is. So what I've done in the past, I have printed out the formulary for CoverRx and sent that to Gilead to show them this medication, even though they have we'll say an insurance plan, it's really a reduced copay card program, because they still have copays with CoverRx, but it's not like a full insurance plan. And I've shown them the formulary to make them understand that this is not covering this medication at all. There's zero reimbursement, and that's when I'm able to. I usually have to get to a certain patient or a person in the chain to understand me. So I would say call them and try to get to maybe a next level, like a manager, to explain this information to them, and just have claims data. If you can get the claims data from the pharmacy showing that there's a $0 reimbursement, there's no PA required, which is also problematic. And you can tell them there's no PA required because there's no option for that medication to even be covered by CoverRx. So that's a tricky situation too. I failed to even think about putting that on there. That's a great one that can be a barrier as far as getting medication, because that person is essentially, I would deem them needing patient assistance, because that insurance does not cover that drug at all. So it is hard to explain that to them. And I usually write letters and make phone calls in those scenarios. But yes, great question. I'm glad you brought that up, because I know you're not the only one, because I've experienced it as well.
Mm-hmm.
Thank you, Samantha. For the sake of time, we do have 2 case presentations. So if you do have a question about the presentation or about patient assistance or insurance, please feel free to drop those in the chat, and then we can address those at the end. But we are going to go ahead and move into the first case presentation. So I am going to turn it over